Welcome, everyone. Thanks for joining. We'll give it just another moment or two. Okay, welcome, everyone. I hope you're all enjoying the start of some longer days ahead. Today, we're excited to hear from two of the PCRC's very own statisticians, Dr. Maren Olsen and Dr. Greg Samsa. And today they will together present on how to work with a statistician. Just a few housekeeping items. Attendees are muted and video cannot be turned on, but you can still engage with us by entering your thoughts in the chat and your questions in the Q&A feature, which is a button in your toolbar. We will address questions at the end of today's presentation or the last 20 minutes or so. So now I'd like to provide you some more information on who our speakers are. Dr. Maren Olsen is a professor in the Department of Biostatistics and Bioinformatics at Duke University Medical Center, the Director of Biostatistics Collaborations for the Department of Medicine, and Director of the Methods Subcore for Duke Center for Reach Equity. Her areas of statistical expertise include methods for complex longitudinal data, methods for incomplete data, pragmatic clinical trials, health services research, and health disparities research. Dr. Olsen has been the lead statistician on several palliative care randomized trials, focusing on both provider and patient level interventions to improve communication and decision-making. And next we have Dr. Greg Samsa, a professor in the Department of Biostatistics and Bioinformatics at Duke University Medical Center, directs the institution's Research Integrity Office, and also serves as Director of Graduate Studies for the Master of Biostatistics program. His time is divided between administration and collaborative statistics, the latter with an emphasis on palliative care and oncology. His portfolio of projects includes, but is not limited to, randomized trials. Dr. Samsa has also previously directed the PCRC's Data Informatics and Statistics Core, also known as DISC, which provides support to investigators, sites, and studies in the statistical and data-related aspects of trial design, quality assurance, data analysis, and reporting. So now I'll turn it over to Dr. Olsen and have her please get us started.
Hi, everyone. It's great to, I guess, quote, like, see you, although we can't see you, but thank you for joining. As you could tell from our introductions, both Greg and I have been collaborative statisticians for many years. We really enjoy working in teams. We really enjoy working on palliative care projects. These slides that we've put together are meant to be hopefully kind of just a seed for further discussion and thoughts. We welcome kind of your input towards the end of the presentation. And Greg, I guess I'll kind of first go through some of the motivation for pulling together a talk like this. So as you know in your research, both research investigators and statisticians speak highly technical languages. And these languages can often be foreign to outsiders, and jargon, that you may be used to as an investigator and we may be used to as statisticians can be intimidating when we start to collaborate and work together. So one of the skills that is really important in becoming a successful researcher is learning how to communicate with statisticians. And vice versa, statisticians are constantly learning good ways to communicate with investigators. Our goal is to help you as an investigator answer the research question, answer your primary aims using the appropriate statistical methods. And there might be a variety of methods that would work and kind of helping us understand kind of the clinical area, helps us weigh pros and cons to making choices about those methods. And I can't underestimate the importance of defining the research question. That's something that we are, as statisticians, are constantly kind of working on with the investigator. And it often is, it might seem the most simple, but in fact, it turns out to often be one of the more challenging and interesting parts of the collaboration. So, Greg, I'm going to kind of turn it over to you.
Sure. I suppose in just a single phrase, how to effectively communicate with statisticians comes down to just speak very slowly and distinctly, and we'll take it from there. But basically, an ideal conversation between a statistician and an investigator, and I think you could already get a sense from Maren that in our collaborative practice, those conversations are very rewarding, creative, and fun. You know, trying to wrap your head around precisely what the research question is, and in a way we can operationalize, and how to appropriately design the study are just very creative and fun. And in this slide, which describes an ideal conversation, it basically takes what Maren has said about the investigator's role, puts maybe a little bit more detail on it, and then it illustrates that the statistician is trying to do exactly the same thing. So in my experience, an effective conversation involves sharing information about your content area. So in my case, it would be statistics. In your case, it would be palliative care or oncology, or whatever the background of the research question is. Then a key piece is restating what the other collaborator has said. So I do a lot of English to English translation. I'll try to say, well, this is what I think I understand that you've told me, or this is what I think I've read about the underlying science. Is that right? And quite often the investigator will say, well, sort of, but here's a more sophisticated way of thinking of it, or mostly right, but this is a key thing to focus on, and let me explain a bit more. And I'd also encourage you all to be brave and to do the same with what you think you know about statistics. So if you tell your statistician what you think you know, and the statistician can help you fine tune it, that'll make you a more effective investigator, and it also will make you a more effective advocate when it comes time to answer questions in professional meetings and the like. So the third kind of piece is the verification piece. Is I'll verify that, yes, what you told me about statistics is mostly right, and hopefully you'll verify to me that I mostly understand the scientific content. So there's a sharing piece, a restating piece, and a verification piece. And those are so consistent across conversations that we literally teach our statisticians in training follow these 3 steps. So next slide, if you would, please. Okay, so I'm just going to illustrate the start of a conversation, and I may or may not read all of these words, but I think you can already see from this first slide that what I've tried to do is state my understanding of the research problem, and then ask the clinician to provide me with some more background about the clinical context. So I'll give you a moment to read the slide, and then when you're ready, Maren, go ahead and go on to the next. Probably good. Okay, so here is a wonderful case. Sorry about the small font, but this is a clinician investigator that that has worked with the statisticians, and so realizes I'm gonna have to explain from soup to nuts. This is actually based on a conversation I had on a project with Tom LeBlanc at Duke, and I very much paraphrased his language. So you can see he's taken a lot of the clinical detail out, and he's put it into terms that lay people can understand. But basically, he's told me that that a diagnosis of acute lymphoma, it comes on suddenly. They have a very, very significant course of chemotherapy that is just really difficult to get through. And he's told me that the therapy is so hard that sometimes they have to pause. And he's told me a little bit about kind of how a typical clinic day works. And he's also told me something that's important to understand the underlying science, which is that they're now trying to provide less and less intensive therapy. They're trying to get by with as little as possible, consistent with achieving remission. And so what that implies is patients might not get the same number of cycles of therapy. And he's also told me that therapy can be delayed. So this is a very experienced investigator and has basically kind of teed up the information in terms that that a non-specialist like a statistician can understand. So if you can use this sort of structure in your communication, your statistician will love you. So next slide. Okay, so now I've tried to echo what I think I understand, and here I'm going to make I'm going to ask for clarification. So I ask, okay, I think I understand you're trying to give as little chemotherapy as possible as long as it's doing its job. So I've restated what he's told me in my own words. And so if things are going well, you'll finish early. Is that roughly correct? And my clinical investigator, tired from using so many words on the last slide, just says yes. So now I'm recasting this in terms that are relevant to the statistical analysis. So what I'm getting at is I'm trying to figure out if patients get a different number of cycles of treatment, should I treat them differently analytically, or should I treat them the same way? And, I might even preface that conversation with Dr. LeBlanc, who I've had worked with regularly. I might even just say, well, this is what I'm trying to get at. But I guess I ask it directly, and he tells me, yes, it's safe to assume that. Occasionally there are disasters. Occasionally we have to stop because of severe adverse events. But that didn't happen in this particular study. And so I kind of do a little teaching and state a general statistical principle that the more similar patients are, the more straightforward is going to be the interpretation of the results. So I get to do a little teaching of statistics, and my colleague gets to do a little teaching about medicine, and we both come away better from the experience. So we actually have a paper. Tom LeBlanc is one of the co-authors. If you want to see the entire conversation, this is the citation. But I'll mention it started out as just statisticians writing. And I asked Tom and Susan Locke, who is our other clinical collaborator, to just comment on it and see if that was accurate. And they got so interested in, well, can we be co-authors? Can we, can we describe the conversation from the clinician's end and so forth? So it ended up being a very enjoyable paper to write. And I'm fairly well reassured that given the clinicians' contributions to the paper, we're probably describing the conversation pretty accurately from their perspective as well. So I think you're back. The floor is yours again, Maren.
Sure. So, as Greg was kind of talking about the details of a specific conversation that he had with a co-investigator, I kind of want to take a step back and walk through another way, or an ideal way, that an investigator and a statistician can work together, and that is through developing a statistical analysis plan. A statistical analysis plan is much more than just the analysis approach. In that way, I actually think it's kind of misnamed a little bit, because it really can serve as an overall roadmap for a project. And I think it's particularly important to have a well-developed statistical analysis plan in kind of smaller, unfunded projects, which may have not undergone external peer review, things like med student projects or senior faculty projects, or things maybe related to a career development award, where you just haven't had kind of the real estate in your grant proposal to be walking through a lot of details. And generally, the project's PI and the statistician work together to produce elements of the SAP. It is important to keep in mind that it's an evolving document that kind of reflects decisions that are made over the course of the project. And while it might seem like a lot of work as we go through this, it might seem like a lot of work to be pulling together a SAP at the beginning. In fact, it often leads to a faster finished product at the end, because developed well, the sections of a SAP are directly translatable to a manuscript at the end of the project. It's also really, really good practice for reproducible research. You have all of your kind of decisions and results all reflected in a single document. And sometimes journals might even require submission of a SAP with a paper. So Greg has actually pulled together this figure kind of describing an analytic framework for a randomized controlled trial statistical analysis plan. He's going to talk about that, and then I'm going to walk through some elements of a statistical analysis plan to kind of show an example of how I used it as a way to kind of collaborate with an investigator. Okay. So Greg, do you want to walk us through this figure?
Surely. And I just highlight, one of the things that Maren has said is really pretty much all statisticians organize their thinking around statistical analysis plans. Really, the question is, are we going to make them explicit? Are we going to share them with the investigator and so forth? One of the advantages of creating an analysis plan is your inference is stronger if you're able to be able to demonstrate that it was pre-specified. An analysis plan can be very detailed, as is the case for a randomized trial that you'd submit to an FDA, or it can be an outline form. It can be conditional. If this happens, I'm going to go in this direction and so forth. Certainly evolving, but there's always a format of a statistical analysis plan that can be useful to you. So this happens to be the analytic framework that most statisticians use in developing a statistical analysis plan for a randomized trial. but it's actually quite general. A lot of observational studies, you can think of it in this way, but this happens to be for a trial. The three boxes on the left, the ABC, are the predictors, and the three boxes on the right are the outcomes. So in a randomized trial, the main predictor is the intervention. So that gets its own box A. And other factors which affect the outcome, other than the intervention, are termed covariates. So there's an arrow for C into the outcomes. And there's one factor, one type of factor that gets its own category, and that is a factor which not only affects the outcome, but also affects the strength of the intervention effect. So if a palliative care intervention around, say, pain management is much more effective if there's a family caregiver versus not, then that family caregiver would land in box B. Statisticians might call that an intervention, and others might call it an effect modifier because it modifies the strength or modifies the effect of the intervention. So going from the left to the right, the boxes proceed from a mechanistic outcome. So if it's an educational intervention on cancer pain, at the very least, it ought to affect knowledge of cancer pain, which could then affect a proximal outcome like maximum daily pain or average daily pain, and then affect a more distal outcome such as quality of life. The arrows become narrower because as the flow of causation proceeds from the left to the right, the effects become weaker because the intervention is very strongly affecting the mechanistic outcome and less strongly affecting the other outcomes because those are all there. So I think it can be helpful to be aware that something like this is the picture that statisticians are going by. And one of the tasks in communicating with a statistician is basically to tell you which variables go in which box.
Okay, so let's transition to kind of some specific elements of the SAP. And as we walk through this, I'm going to walk through the specific example that I worked on actually with a medical student, and this is related to my role in the Reach Equity Center. Although it might seem trivial, it's actually really important at the top of the beginning of the SAP to include the title, the team members, and any kind of relevant deadlines or products that are that kind of are the plan, the purpose of this SAP. And one of the reasons why is that it's important to actually include a header like this is, you know, for example, I work with one investigator who does glaucoma adherence research, and to me, all of her projects sounded really similar, and I had a hard time kind of keeping everything straight. And so we had to kind of come up with, you know, specific titles that, you know, again, this is a tool for a vehicle for kind of communicating clearly, and it helps a statistician kind of keep organized between all of the different projects that they're working on. You know, so another important element of the SAP that we very much rely on the investigator helping to provide for us is, you know, a background of the project so that we can understand some of the clinical context, including references. This will then end up serving as kind of a first draft of the introduction for a future manuscript. We also need to include the study objectives. And as we are including the objectives, and in this case, our primary objective in our example was to look at the association between patient perceptions of care as measured by a particular survey called the IPC, and our outcome variable of glycemic control in a cohort of patients with type 2 diabetes. And as I mentioned earlier, one part of a SAP will reflect decisions that are being made. If you think about kind of defining an outcome of glycemic control, there's a lot of different ways that could be defined. And you can see that in our SAP, we've included exactly what our primary outcome variable is and how we are going to define glycemic control. We are going to collect all the A1 during the past year, but we're only going to be looking at the most recent value. Again, this is something that will need to be included in the manuscript, and having everything specified up front in the SAP will save you time in the law. The kind of the questions, because as Greg was alluding to, as an investigator is talking and describing their aims, the statistician, their wheels are turning with, okay, what analysis technique am I going to use? What assumptions do I need to make about the data, et cetera? And so we're kind of at parallel thinking about what we need to do given the information that you're giving us. So in the first version of the SAP that I was working on with this investigator, she had written that her first part of her primary hypothesis was that higher patient scores on the IPC survey will be associated with lower A1C levels in each subgroup. And when I read this, I thought, oh, okay, that's interesting. Does she actually want to analyze each subgroup, in this case reflecting Black and white patients? Does she want to analyze those separately? I'm not sure. And secondarily, the second part, she stated that she anticipated a differential association between IPC and A1C for Black as compared to white patients. And my statistical brain is immediately thinking, oh, okay, that's an interaction model. That's something, and I'm also thinking, okay, well, if you're thinking about an interaction, do you want to specify a direction for that hypothesis? So you can see just from comments in me reviewing the SAP, it wasn't completely clear to me. And then we had a conversation and determined that, in fact, the investigator wanted to look initially at the entire sample overall. She did not want to look at Black and white patients separately. And then secondarily, she did not want to specify a direction of a differential association. She just wanted to say that it differed. Another really, really important part of a SAP is to include, is to kind of work through how you're going to be obtaining your sample. If it's a secondary study or a randomized trial, these kind of having a template for how you're getting down to your analytic cohort. And you can see this was just a prospective cohort, a cross-sectional cohort, but coming up with this diagram of how we were going to figure out how we were enrolling participants and how we were going to kind of come up with our final sample, this took many, many meetings and conversations. And reflecting those final decisions in the SAP was really important. And again, we are able to immediately fill in those numbers and put it right into the final manuscript. Then, of course, also the SAP also needs to include statistical methods. And this part, generally the statistician is going to take the lead on that, on writing information about power and sample size calculations, writing an overview of a plan for each hypothesis. But importantly, one thing that we really, really rely on our investigator team to help us with is kind of a priori defining how decisions will be made. In this case, we defined kind of what was clinically significant with each of our outcomes of interest. And again, this is something that then should be reflected on our primary manuscript and reflected both in the introduction as well as the discussion of the results. Another really important part is to actually include table shells that are anticipated for the final manuscript. And one of the reasons why it's important to include the table shells is because, again, this is a way that we can kind of clear up communication and clarify things. For example, in the first version that the investigator included, she had a separate row for each item of the IPC, and she was thinking, okay, we're going to have an overall mean, and then for an overall relationship between the IPC and A1C for each item in the IPC. And when I saw that, I was like, oh, I had no idea that investigator didn't understand that the IPC is actually scored as 7 subscales, and that we need to be thinking about everything in the context of these like subdomains. And I think if we hadn't, kind of already drilled into including table shells, that confusion would have persisted with us not realizing that the confusion even existed. So you can see that the second version of our table included rows reflecting each of the subdomains and how we were going to be measuring that relationship. So we're kind of wrapping up in our points here. It's, as you can see from the examples that Greg and I have been talking about with you all during this webinar, not once did we actually talk about data, right? All of these conversations are happening at the project inception, at the ideas, at the project brainstorming development stage. And it's really, really important to assemble a statistical team right at the beginning. Think of them as kind of a core group of your research project and research investment. The SAP is a working document, and statisticians, we are involved in a lot of studies, and we can help with more than, quote, just the analysis approach. We have a lot of experience with kind of giving input on study design, recruitment, survey collection, et cetera. And so think of us kind of as integral team members. Another thing that I hope that we've emphasized in the points that we've been making is that every interaction is an opportunity for an investigator and a statistician to both learn something. Both Greg and I have been part of collaborative teams for over 20, 30 years. And I don't think we would continue to have this job unless we were always learning something. That's like one of my favorite parts of a collaboration. And I really value learning things, and I really value kind of bringing, translating some knowledge to the investigator team as well. The SAP should reflect all phases of what we're trying to do with our project, and as I mentioned repeatedly, will lead to a higher quality finished product. And that was it for our slides. I'm seeing at least one thing in the chat. Oh, okay, that's Naomi. Greg, go ahead and chime in with your final thoughts.
Surely, yeah. Maybe I can make a comment while people are putting together their questions. Obviously we're trying to establish a common language so we can effectively communicate. And one of the things that can support a common language are pictures. The consort diagram that Maren illustrated is a picture. It's a picture of a flow chart with numbers added. The table shells are a picture which both parties can understand. A diagram of the data collection schedule, the study design is another picture. The structure of the data set. What data will we collect? Will the patients be the rows? Will the variables be the columns? That's another form of picture. So at least one thing that I would propose to you is a good place to start to establish that common language is to figure out a picture you can draw.
Thank you so much, Dr. Olsen, Dr. Samsa. We'll wait a few more moments for attendees to finish typing in those questions. In the meantime, I do want to advertise next month's webinar, which will be things you really need to know when you submit your NIH grant. Don't miss that. It's with Dr. Karen Kale, and that's on April 19th. We'll also be sending a post-evaluation so we can continue to improve all of our IDC offerings. And if there's no questions, we can certainly give you some time back in your day. Oh, I see one. How to manage when a PI and statistician have a disagreement about an analytical approach and can't reach a compromise. Who would like to take that on?
Greg, do you want to go first and then I'll chime in, or would you like me to?
If you want to start, that's fine.
Okay, hold on, let me.
Or I could take
I'm
it if
thinking
you
about it. Well, no, I guess what I'm doing is I'm thinking about a specific example that I've been in where it wasn't that we couldn't reach a compromise. I would say that more often what might happen is that an investigator has been used to doing things in a certain way, is used to kind of specific methodology, and then I was new to the team, or the project was slightly different, and so I proposed, did research on the methodology that the investigator was used to. I did my own research, kind of figuring out, pros and cons to that methodology versus a different methodology, and generally how I have approached that is just by that, kind of like acknowledging that there are pros and cons and kind of explaining why I feel like the pros of the approach that I'm suggesting kind of outweigh the cons of the approach I'm suggesting. One thing that I actually think is important to keep in mind is I'm not a big fan of, constantly thinking about like sensitivity analyses. Some investigators like to do that where, okay, well, we're going to propose this one way and then we'll examine A, B, and C as, quote, like sensitivity analyses. And one of the reasons I'm not a fan of that is because often those sensitivity analyses are actually answering different questions, and you have to be really careful that if you get a different result, it's not because the primary approach was an incorrect approach, but it's because, in fact, the sensitivity analysis is answering a different question. So I think that I would hope that kind of the reaching the compromise can happen by by really exploring the pros and cons between the methods with the investigator team. I don't think I've ever been in a situation though where we haven't been able to resolve it. Usually, we end up being able to meet a compromise by thinking about all of those and being really thoughtful about the different decisions that we're having to make.
Yeah, my experience has been similar to Maren's, and the way I conceptualize, and I think very, very similar to what Maren said, is it's important to more clearly define the disagreement. And in practice, one or both parties are working with insufficient information. I recall situations where, as a statistician, once the investigator better explained the underlying science, the study design, et cetera, that caused me to reconsider my recommendation. And I can also think of situations where once I better explained the rationale for the statistical analysis, they reconsidered. A piece of defining the disagreement is I'll describe from a statistician what I understand the clinician is saying, what we're saying. I ask the clinician to do the same. And one thing that I've found helpful as a statistician is to distinguish between cases where there's a wrong path and bad things happen if you follow it, versus cases where you could do things a number of different ways. So as part of defining the disagreement is also describing the how serious the implications are in going one route rather than the other.
Thank you so much. Another investigator asks, how do you find a new statistician, especially when yours has retired?
So I would hope that your institution has, some, if there's a department of biostatistics or division, of that kind of has more quantitative people in it, kind of reaching out first to the faculty, the researchers kind of in that department. That would probably be the first place that I would be going. At Duke, where Greg and I are both faculty at Duke, we have biostatistics, epidemiology, research and design core that has a small army of faculty and staff statisticians affiliated with it. And we often, and we work on collaborations across the university. And the leadership of that core is really well versed in kind of all the statistical resources across campus. So even if a group may not immediately have someone available for you to work with, they often know how to direct you. So rather than you trying to kind of figure all of that on your own, I would highly recommend you kind of reaching out to the quantitative groups on campus, because they tend to know each other and know where the resources are. That would be the first place that I would recommend.
Yeah, and I translate that into find a navigator. At Duke, those navigators can come from our existing research support groups. And depending upon the institution, they either have effectively functioning ones or not. But another navigator is like the chair of statistics or biostatistics or something like that. But all of these navigators share the characteristics of pretty much knowing everybody and being able to converse with you to try to figure out what your needs are, and so to know what type of people to recommend.
Thanks so much. That's really important advice. And our last question from Heather, she thanks you both very much for your presentation, for sharing your collaborative article. For the dissemination processes, might you recommend any data visualization resources such as websites, text articles that you have used from you to your PIs so we can speak to each other in the diagrams as you mentioned?
Greg, why don't you dive in on that one first?
Okay. Is Heather able to be on the audio to slightly clarify her question, Naomi?
Let's see. If Heather, if you could raise your hand, then I would be able to let you in. Hi, Heather.
Hi, can you hear me?
Yes.
Fantastic.
Yeah, so I was hoping that you might clarify your question or just give a bit more background.
Sure.
That would be wonderful. Thank you.
I mean, I'm thinking from your expertise of, PhD biostatistics, and there's so many ways to represent data and visualization. And so sometimes I'm a PI. So, as a PI, I have these, dreams and thoughts in my head, which don't equate to what I can have the quantitative data do. And I find myself like literally taking a pen and paper or pencil and like, can we do this? And of course, we can't because I don't have the knowledge of what the data can be visualized at. So I was just curious if there were specific websites, textbooks that kind of give me, the PI, some grounding in that space. So then I can speak back and forth with my statisticians using diagrams that actually are usable.
Well, one thing you could do a web search on is DAGs,
Okay.
directed acyclic graphs, and there's plenty of accessible sources around that. DAGs are a way of describing the various interrelationships among the variables or the constructs in your model. As a matter of fact, what our slide on the standard analysis plan for a randomized trial is also a form of a DAG. Basically, here it's a simple one because all the arrows go in one direction. But you could imagine a more complicated observational database or something where the science is more complicated, where you have lots of boxes and lots of arrows. So that's that's one of the things that you could that could be a potential source. I guess the second thing that I do is just provide encouragement. Is I encourage my clinical collaborators to do the same thing. Just draw pictures, and even if the pictures don't directly map to a statistical approach, it's very valuable to me as a statistician because now I understand how you conceptualize things. I'll probably get a better sense of the underlying science. I know what to query. Well, gosh, I'm not sure what this does. Can you tell me more about what you were thinking, et cetera? So I would encourage you to continue drawing those pictures, even if the first draft of the picture doesn't end up working perfectly, because it ought to, at the very least, stimulate the right questions from your statistician.
Thank you.
Thank you so much. Any final words, Dr. Olsen, Dr. Samsa?
I was just going to say that I just there's one browser example called Daggy that I've used with investigators. So you might want to check that out.
Thank you.
A tremendous amount of gratitude to you both for your roles with the PCRC and for giving this talk today. Stay tuned next week. I'm sorry, next month for that talk with Dr. Kale about how to prepare to submit, what you need to know when you submit your NIH grant, and stay tuned for the post-evaluation. Thanks everyone for joining, and take good care.